Our presentation on pregnancy-induced hypertension will be presented by Fiona Pazuka and Nicole Nelson.
According to the World Health Organization, at least one woman dies every 7 minutes from complications of hypertensive disorders of pregnancy. Though there is a broad classification of pregnancy-induced hypertension, which include gestational hypertension, preeclampsia, and eclampsia, preeclampsia is the leading cause of maternal and perinatal morbidity and mortality. There are several key risks associated with severe hypertension, which include but are not limited to heart attack, renal or cardiac failure, and cerebrovascular accidents. In the United States, about 15% of maternal deaths are attributable to hypertension, making it the second leading cause of maternal mortality. Three of the primary characteristics that are common in pregnancy-induced hypertension include high blood pressure, protein in the urine, and pathological edema. There are a few considerable risk factors for pregnancy-induced hypertension, which include but are not limited to null parity, multiple pregnancies, gestational diabetes, and obesity. On the right, we have a chart to display a comparison of the various classifications of pregnancy-induced hypertension, and we will discuss it a little more in depth on the next slide. Since there are different classifications of pregnancy-induced hypertension, how do you go about diagnosing it, you may wonder? For gestational hypertension, once the parturion has delivered, the patient will actually return to normotensive levels. These patients usually have a systolic blood pressure of greater than 140 or diastolic blood pressure greater than 90, or both. Other key factors of gestational hypertension include the absence of proteinuria and seizures. It is also noteworthy that on a severity scale, gestational hypertension is mildly severe. A patient diagnosed with preeclampsia typically exhibits a systolic blood pressure of greater than 160 systolic or a diastolic blood pressure greater than 110 and or both. Increased thromboxane levels compared to prostacyclin leads to vasoconstriction, platelet aggregation, and decreased placental blood flow. This usually occurs at a ratio of 7:1. Proteinuria is also commonly observed. Generalized edema is also a frequent manifestation. Mothers with eclampsia usually have preeclampsia along with seizures. Preeclampsia impacts around 5 to 7% of pregnant women, with its exact cause remaining unknown. However, individuals at higher risk include those with chronic renal disease, mothers under 20 years old, mothers over 35 years old, and those who are homozygous for the angiotensinogen T235 allele. This condition is characterized by elevated vascular resistance and decreased placental blood flow, which then leads to insufficient oxygen supply to both fetus and placenta. The release of cytokines leads to dysfunction of the endothelium, and this is common in the diseased placenta.
So the case study that we'll be reviewing today is a 28-year-old female, gravida 3, para 0, abortions 2 at 32 weeks along. So she's had 2 miscarriages, one at 8 weeks and the other was an ectopic pregnancy. Her past medical history includes asthma that's controlled with albuterol and depression. So she came in on January 2nd at 9 a.m. and she presented with facial, upper extremity, and lower extremity edema, severe headache, severe lower abdominal pain, hyperreflexia, and she had no fetal movement. Her blood pressure was 180/120, heart rate is 100, respiratory rate was 21, and temperature was 37.8 degrees Celsius, and they found +2 protein in the urine. So what do we think her diagnosis is? So let's walk through it. So for timing, she is currently after 20 weeks, so she's at 32 weeks gestation at this point. So this would rule out chronic hypertension. The severity, so right now her blood pressure is pretty severe. Proteins in the urine. So she does have proteins in the urine, so this would rule out just plain old gestational hypertension. And now we're down between preeclampsia and eclampsia, which is differentiated between the presence of seizures, which she does not have. So her diagnosis would be preeclampsia. So 4 hours have passed and the patient still has not gotten any treatment. So her symptoms are getting more severe. She has worsening headache, blurred vision, severe epigastric pain. Her blood pressure is still severely elevated. Her protein in the urine has gotten worse. So what are our concerns? So first, we're concerned about HELLP syndrome, which stands for hemolysis, elevated liver enzymes, and low platelets. HELLP syndrome occurs in 5 to 10% of patients with preeclampsia, and she is at an increased risk of DIC and bleeding from the liver if she has HELLP syndrome. In this patient, however, her AST and ALT levels were normal, and her platelets were 328, so HELLP syndrome was ruled out. The next concern is eclampsia, so since the patient has not received any treatment yet, and her blood pressure is still severely elevated, she is at a super high risk for seizures. So the healthcare team goes ahead and starts treatment. So she receives a 5-gram MAG bolus and then is started on a maintenance infusion of MAG at 1.5 grams per hour, and she receives 3 doses totaling 15 milligrams of hydralazine. So almost 24 hours after admission, the patient undergoes a C-section delivery, and the blood pressure improved overnight from the MAG infusion to 130/80. The mom was found to have placenta accreta, so her uterus was repaired, and then she was transfused with 2 units of PRBCs. The neonate came out weighing 1,700 grams. APGAR scores were on the lower side, so it was 5, and then 7, so the neonate was transferred to the NICU for respiratory distress. And ultimately, the study found that there were major system failures with this patient in particular, so there was a lack of a high-risk OB management team. The treatment to start MAG or give hydralazine was delayed almost 4 hours, and the C-section was also delayed until senior doctors were present, which wasn't until the next day. So the study found that mainly high-risk pregnant mothers should be monitored more closely at their hospital facility, and the decision to terminate the pregnancy should have been made without delay when the maternal or fetal condition worsens, which happened in this instance. Anesthesia implications. So for preeclampsia, it's important to ensure proper fluid balance. Even though these patients are hypertensive, they do have leaky vasculature, and also anticipate a difficult airway due to swelling. You need to be ruling out thrombocytopenia before a neuraxial block. MAG also helps to relax the uterus, but at the risk of postpartum hemorrhage, so it's important to remember that. Patients on MAG therapy will have an increased sensitivity to neuromuscular blockers. The hemodynamic response to laryngoscopy can be blunted with labetalol, esmolol, MAG, or remifentanil. Patients with preeclampsia will have an increased response to sympathomimetics and methergine. For eclampsia, it's important to administer seizure prophylaxis with MAG sulfate, so the loading dose is typically 4 grams over 10 minutes with an infusion rate of 1 to 2 grams per hour. And it's important to monitor and treat MAG toxicity if it does come up. So typically, deep tendon reflexes are preserved, so after there is a loss of deep tendon reflexes, the anesthetist starts to worry about these other effects like hypotension, respiratory paralysis, etc. So if there is signs of MAG toxicity, then treatment with calcium gluconate is done. So that concludes our presentation, and here is a list of our references.